there are, of course, complications that overlap in both types of tubes. I'm going to talk about safe non-valve surgery. This is something very close to my heart. I do wherever possible non-valve surgery, and I don't have any relevant disclosures for this talk. It's not moving again.
I'll take the time to introduce you. She's a very, very competent surgeon. As you can see, people refer her their problems to her, and she keeps redefining her boundaries. That's what I like about Vanita. You keep evolving. So over to Vanita Pathak.
Right. So we don't have too many drainage devices available in India, but we do have some that are indigenously made. The ADI, of course, both 350 and 250. It's designed, the prototypes were all from Barweld. And of course, now we have the Ahmed ClearPath available, both 350 and 250. So the non-valves are, both 350 and 250, but it is really the 250s that are taking over. The recently available ADI 250 being very, very advantageous in terms of it being cost effective. And you heard about Paul glaucoma implants, still not available. We are hoping it will be launched in this meeting for India. So the main issues with non-valve tubes, of course, is hypotony. That's it. So every effort has to be made to control this hypotony. And of course, you need protection of endothelium. This is, these, in my opinion, are the two biggest things related to tubes, hypotony for non-valve tubes. And so protection of the endothelium is a concern for all types of tubes. So the expected post-operative course of a non-valve tube is hypotony. So you have to make preemptive efforts to control this initial hypotony. How can you do that? You do with temporary occlusive ligatures, you use ripcord. I use ripcord all the time now. When the tube is occluded, it results in early post-operative hypertensive phase. This is temporary, okay? This also can be managed. So I'll just list out a few procedures and then we'll see them how they can be done. So to prevent the early post-operative hypotony, you use a ripcord. You either use Supralon. This is our indigenously made from Arvind 30 nylon, or Supramid, which is not available in India, or you can even use the 40 Proline. And you use temporary vicryl sutures as occlusive ligatures. You can also use a little bit of heavy molecular weight OVD, and you can do a two-stage procedure. You can first implant the plate, and then 4 to 5 weeks later, when a thin capsule has formed around the plate, you can then introduce the tube into the AC or sulcus. Sulcus is my preferred destination. Intraoperative modifications that you can do to overcome the initial hypertensive phase now, because you've occluded the tube, is venting slits or fenestrations. You can use a vicryl stent as well, or you can restart medications, or you can even do an orphan trabeculectomy, meaning without antimetabolites, something which is only expected to last 4 to 5 weeks, and you're not going to work heavily with it to make it succeed. So where non-valve tubes are concerned, my biggest tip is to prepare the plate before you actually put it in the quadrant. And that it helps, making the surgery very, very controlled. And when you do the occlusive ligatures, turn the plate over so that you don't have a knot on the anterior surface, so that if you need to laser it, you can still laser it. And I have done that several times. So just let's have a look at Ahmed ClearPath 250 first. Basically, it comes with a pre-placed stent. I leave it in position all the time. I do the occlusive sutures. You can see it's the undersurface where the knot is. And then I'm doing fenestrating slits anterior to it, and I'm also leaving a 6-0 vicryl stent. The same thing can be done on a ligator block. It's much more controlled if you're just starting. This is a steel block, basically, where you can use 30 gauge needle to create the fenestrations, and then you can occlude as well, as you are seeing there. And always check, keep checking that you have occlusion and you are getting initial filtration only anterior to it. Now this is in slow motion. What I wanted to show you is how you can fold this plate like a taco and hold along the long axis of that plate and then insert into the pocket very small conjunctival incision, not more than 5 millimeters, and then just grab hold of the distal end of the plate closer to the eyeball and just unfold it. Very advantageous. Remember, these Ahmed Cleopats have these dog ears, so you don't have to go as far back as well to suture it. You don't need to go 10 millimeters. You can do it at 6 millimeters. And contrary to what you've heard so far, I leave my tubes pretty long, and I'll tell you why. Okay, this is in the sulcus, and most of my tubes are in the sulcus. I don't, especially in aphakic, pseudophakics, I would not put it in the AC. And then the rest of the surgery is then very much similar, except when you have the ripcord, you insert it into the inferotemporal pocket, and the free end, I put it under the patch graft. I used to use a lot of corneal patch grafts. Unfortunately, I don't have too much access to it now. I tend to use the rims, the corneoscleral rims that are discarded after PK surgery also. And then you close it with, this is going to be a game changer in India. You can see such a small incision through which I inserted the AIOS2025. This too, I'm placing a ripcord because it doesn't come with a ripcord. This is Supralon, 30 Supralon, and the rest of the procedure as you just saw. But again, what is important is that you can also fold it just like that and place it in the pocket. And that once it's in the pocket, you just unfold it and then suture it. I use 6-0 stay suture. I pass it through the holes, and then I do safety sutures on top of it with 9-0 nylon. And AIOS2025, of course, requires dissection of the muscles, as you all know. And the rest of the preparation is the same. Vicryl stents, fenestrating slits, whatever you want to do. Here I'm placing a proline because it doesn't come with the ripcord, and preparation of the plate prior to putting it into the pocket is useful. And the 350 also here being prepared on a ligator block, and this also requires placement under muscles, as you can see there. Just forward it for you. And because it has dog ears, you don't have to go so far back. Okay, endothelium protection is very important, so that includes placement of the tube and the length of the tube. Pseudophakics, aphakics, preferred destination, sulcus. Phakic individuals, if there is cataract, do surgery together with it. If the lens is clear, that becomes contentious. And pars plana, I reserve when patients have trauma and things like that. You can see here in this particular case, just fast forward it for you. I'm placing it in the PI of the trab. I hope you can see that. Visibility of the tube there. And you know, in PKs, in all these conditions, I would always do tubes in the sulcus. This one, patient is awaiting a DSEC, and I placed a tube in the sulcus. And ICE syndrome, all the time, I place it in the sulcus. There is retraction. Please remember, there is retraction. So longer is better. and longer is better. Here you can see in an ICE syndrome patient, the tube has retracted. Why longer is better? I skip this now. Longer is better is because endothelial cell loss will occur where the tube enters the AC or the sulcus, but a longer tube, even in AC, prevents that excursion from the tube to the endothelium is rather long. So when the eye is being squeezed, it actually does not touch the endothelium at all. And this has been proven. There are several studies. This has caught my attention many times. And also, of course, in shallow ACs. Please remember. And he was saying Venflon cannot be put. I have put Venflon angiocatheter inside the eye as well. It's not easy, but you can do. The end result with non-valve surgery, you can look at the bleb. It's beautiful. Compare it to an AGV bleb here in its glorious hypertensive phase, unfortunately, really high. So knowledge of and execution of meticulous intra-op maneuvers result in safe non-valve surgery, and placement of the tube in the sulcus is protective for the endothelium. Thank you so much. I'm really sorry I overstepped.